Okay, good. So as I mentioned, here is the folder for Google Drive that I put together. And everything, it's going to be a little reference guide for you. Specifically, this will have links to YouTube videos. So if you go to this, I've developed a whole playlist on how to document certain things within Athena. So a lot of it might be kind of my best features that I have, but also it has like documenting a toenail injury, documenting x-rays, insertional Achilles tendonitis, how to use macros, ingrown toenail paronychia, doing a note for a diabetic, procedure templates. So all these are videos that I made to help other people, and I think they'll help you as you do this. That's the videos. Procedure mapping. These are all the different types of procedures that I do in the office. You don't need to be familiar with all of them, but for example, I might talk about an AFO, which is an ankle foot orthotic. And so you can kind of look at, there's different types of notes, and these procedures are connected to like dispensing notes. And I'll kind of go over that as we do it, but I can only bill something once I dispense it, like ankle foot orthotics. I can't do it when I'm casting them, but only when I'm dispensing it. And these are going to be the procedure codes. These are automatically added to the note. Most everything that I do automatically adds the procedure code within the medical record. So these are the different types of AFOs that I use. Here's cantharidin. This is, for example, we call it, and I put little kind of things to help you. When I talk about amnio injection, that's called amniotic injection. When I talk about Beetlejuice, that's called cantharidin, which is something that destroys lesions, usually used for verrucas, which are warts. If I talk about laser wart, that's what this Cutera laser treatment of verruca is. When I talk about ulcer debridement, here are all the ulcer codes, and there's different depth levels, and those will always populate the procedure code. When I talk about focused shockwave, that's EPAT focused. Radial shockwave is radial. Combo that's both radial and focused, and I'll talk about that. Cyst removal is when I remove ganglion cyst. Wart removal is when I actually excise it, and I'll give you a measurement, and that measurement will be right here based on the excisional amount. So I'll measure it, and this is what I call a flexor tenotomy. This is where I cut a tendon in a toe. These are I'm talking about the most common ones I do in the office. Foreign body, complicated or simple. If it's a foreign body, which would be like you're stepping on a sliver or something, or a pebble or something else that goes into your foot. If it's infected, it's called a complicated one. If it's not complicated, that's a simple one. And so these will go in. These are fracture codes. So based on what bone someone fractures, I'll have you add a fracture code in it based on metatarsal, great toe, digit, calcaneus, and I'll have to be a little bit more verbal while I'm doing that. Hardware removal. This doesn't happen that often in the office. Incision and drainage. It can be simple or complicated. The most common thing that we do in the office is something called a paronychia, which is an incision and drainage of an ingrown toenail. But if it's more complex, such as I need to put someone on an antibiotic, or maybe they step on something and it goes really deep in a big infection in their foot, it's called an IND, multiple or complicated. And then if it's something real complex, it's up here. So I'll tell you which level. If you have a hematoma, which is a blood blister, and I'm incising that. There's also injection codes. I might inject a ganglion cyst. I might inject a large joint, which would be like an ankle joint. I may do a neuroma, which is a nerve that's between the metatarsal heads in the foot. I don't really inject scars that much. I have a lot of these. I use some of them more common than others. A small joint, which would be any other joints in the foot I'm injecting. And all these will pull up the injection code and what I'm putting in there. And then I'll let you know how many milliliters of the injection material, and I'll show that to you in a second. Injecting the tendon, like injecting, for example, one of the tendons that's inflamed. If I'm injecting a tendon sheath or ligament, that would be like the plantar fascia, which is very common that I use. Debriding a callus is called a keratoma, and depending on the numbers, it might be 1, 2 to 4, or 5 or more. That's how we document in the note. If we do a wart treatment, once again, this is a lesion destruction. This is different than the cantharidin. This is one that we use with salicylic acid. So it's a different type. If I do a matrix or a matrixectomy, I call it, it's where you take out an edge of the toenail and you kill the root with a chemical called sodium hydroxide. A total matrixectomy is where I take out the whole toenail. Nail avulsion, where I pull off the nail, one nail or additional nails. A partial nail, which is where I pull out just the side. This is a toenail that's not infected. Nail biopsy, where I take a biopsy of the nail if I'm concerned about any melanoma. Nail debridement, so and this is what we do on Fridays in the office. So if it's 1 to 5 nails or 6 to 10, for a lot of these you're going to do new from old notes, so you don't really have to. You can just put in the new from old. The big challenge is like if it's 1 to 5, you have to actually note what nails, and I'll show you how to do that in a second. What nails you do. Orthotic casting. We don't do much PRP here. We don't do many shoes here. Skin biopsies, I use biopsies quite a bit. So a single lesion or an additional lesion. I usually use a 2 millimeter punch biopsy, and select the size as you're doing that. Maybe a strapping of the foot. I don't do that much. Strapping of a toe fracture I might do, where I'm strapping it. And then subungual hematoma, which is a blood underneath the toenail. Trimming of nails. And then una boot, which is a compression boot around it. So this is, if you ever want to go back and kind of look what types of things I do, they're all right here. These are all the procedures that I do. I don't do anything that's not here. So I pulled this over specifically to help with that. So those are procedures. Any questions on that? Or you just want me to keep talking? I feel like I'm going kind of fast. Chad, Drew, or Ben, any questions? No?
I think everything's clear at this time. Definitely appreciate the detail.
Okay, physical exam findings. This just talks about a physical exam, what a foot pain normal exam is, a routine nail care exam is, ingrown toenail exam, and these can be added to other notes. So what I did, I tried to explain when I use these and how to do these, okay? So the most common one I do is like a foot pain normal. And then on top of that, let's say they have nails and calluses, I can add that to the foot pain normal. Or if they have a routine care visit, I can add a wound to it, for example. Or if they're doing a comprehensive diabetic foot exam, I can add that to a different one. Or a post-op can be added. These can be added to other notes. So the main notes that you're going to be using are going to be these ones for the new. Pretty much all new patients are either going to be a foot pain normal, a routine care, which is basically nails and calluses, or like an ingrown toenail, and then or a comprehensive diabetic foot exam. And then all these other ones are the most common things you can add to those notes, and I'll show you how to do that. So the main template is this, and the other ones are like that. And then so usually when you add these to them, I have it all written out for you. When there's a follow-up visit, you can use the previous items. You can find these others under saved findings and templates, and most are repetitive. But the common exam findings are divided into cardiovascular, skin, gait, like how they walk, musculoskeletal, ankle, and foot. So basically, this is an example of what it'll look like in the EMR under saved findings. And the most common ones I use are like the CDFE normal, foot pain normal, ingrown toenail, or routine. These other ones you're not going to use as much depending on the doctor. And here are the normal templates. So the difference is a regular template doesn't pull any or pre-populate any data. The saved findings, these pre-populate the normal values. So I tend to use the saved finding ones, and then because it just takes a lot more work to use the templates that are empty. Okay, so for example, here's a foot pain normal. Here's the template itself, and you can see it actually pulls in all the normal values. So normal for the pulses, the dorsalis pedis, posterior tibial, edema, varicosities, it pulls in everything normal. And then all we have to do is I will say, well, let's say this patient has, I don't say anything. If the pulses are normal, it's normal. Let's say they have edema on the right foot. You just change the edema. Let's say they have foot pain to the plantar medial heel, which is a pretty common area. You're just going to change that one portion of it. Okay, and I'll tell you what portion that you're going to change with the foot pain normal template. But it's going to pull in normal, and I'll tell you any of the abnormalities. Same thing with routine care. It's going to pull in normal, and then I'll tell you any of the abnormalities. Now, these are for new patients because follow-up patients, you're going to just mostly do new from old. So you're going to do a new note from an older note. Okay, so same thing. I'll tell you which toenails are bad, if they have any neuropathy, which is lack of feeling in the foot, or anything else like that. Ingrown toenail, same thing, pulls in the normal values. And then now these are the things that can be added to the other notes. So let's say we're doing foot pain, but they also have some calluses and some nail findings. You can add this little section into the dermatological section and just change what's in there. And it'll change what, same thing right here with wounds. Within a wound, it doesn't pull in normal values, but you can see here it has all these kind of things for a wound. So the wound type, the length, the tissue depth, the ulcer stage, the type of the drainage type, drainage amount. So most of these things are pretty repetitive, and I'll kind of go over with them. In the beginning, you might have to open up the note just to because I usually go in there and click all this stuff. You're going to be clicking in the stuff for the wounds. But once again, you're going to be putting in it, and then new from old, you could just change what else is changing. And normally what's changing is the size, right? So you're going to have the size here, and then the ulcer location debrided, and then the initial one. So the first time we're going to put in the initial date and the size, and then each additional visit, we're going to just be changing the depth of it and other types of stuff like that. Okay, so this is for wounds. And this is a comprehensive diabetic foot exam, which we do usually once a year for diabetic patients. Once again, it pulls in all the information, and then you'll just change what's abnormal in there. This is a post-op exam that's going to pull in if I'm doing a post-op visit. The main difference is the inspection section. So you can see this inspection section, and I'll teach you to fill that out, okay? But you click the inspection, and then I'll have information about the surgical site. Wart and lesion only, these can be added to other notes. So basically, you're going to have, these are for, mostly I use these for warts, right? So you're going to put the size of it, if it's well circumscribed, if there's infarcted capillaries. I don't usually use all these things. Some of these are made for like melanomas and other dermatological things, but this is for lesions. So those are the physical exam findings. Here are the different types of orders. I put here, these are all the orders that I do. You're probably not going to see any other orders that I do. So I do radiological orders. So we might do a US foot, which would be an ultrasound of the foot. X-ray, XR means X-ray. Ankle 2 views or ankle 3 or more views. X-ray calcaneus 2 or more views. The foot 2 views, foot 3 views. MRI of the foot with or without contrast, MRI of the ankle with or without contrast, and then a CT is a CAT scan of the foot or the ankle. Normally my staff are going to be putting in these orders, and then I will go in and explain how to fill out like what the abnormal sections are of the radiological exam. Other types of exams I do are labs. I do a CBC occasionally. The most common one blood test I do is called a LFT, which is a liver function test. I'll order that to evaluate for nail fungus if I'm going to give them a medication. Uric acid is for gout. Occasionally I'll do a hemoglobin A1C, which is a 3-month value of their blood sugar levels. PAS is a nail exam for fungus. A skin biopsy, I do these quite a bit. And then pathology if I'm removing something. There are other types of orders that I do. I know we're not starting with these, but later on we'll be doing these. So physical therapy is the most common thing that I do. Diabetic shoes, if I'm sending them out, we don't do diabetic shoes in the office, but I'll send them out for an order for diabetic shoes. Custom orthotic. Pedorthist is someone that alters their shoes and shoe gear. Interventional radiology referral is someone for if they have poor circulation. Weight loss referral is if someone's trying to lose weight because they're on diabetes. A vascular referral is that they have circulation problems. A ferro wrap or circ aid. These are compression wraps that some patients get. Wound center referral. There's 2 places locally. One's the Limb Preservation Clinic at UMass, and one's the Wound Clinic at St. Vincent Hospital. Then there's the nursing, visiting nursing if they're elderly and need like wound care help at their home. Interventional radiology, I think I already put that on there. Lymphedema clinic is a clinic to help if they have really bad circulation. Venous duplex ultrasound. This is I'm looking for a blood clot. I might send them to a vascular lab for that if I think they have a blood clot. Ankle brachial index. We usually do this in the office, and we call it PadNet. But occasionally their insurance won't cover me doing it, so I'll send them out to either UMass, which is University of Massachusetts, or St. Vincent Hospital. And then a bone stimulator. This is used for slow healing bone, okay? And I don't do those that often. DME orders, which is durable medical equipment. This is stuff normally that we have in our office that we will dispense to patients or order for patients. It's called durable medical equipment. A night splint is something that holds your foot up straight when you're sleeping. Usually we use it for equinus or a tight calf muscle. Typically it's for Achilles tendonitis or plantar fasciitis. A cam boot, which is called a walking boot or a cam boot, it can either be a short or a tall. There's two types. And really depends on the injury. They can use a short one or a tall one. Like I mentioned before, AFO is an ankle foot orthotic. Okay, these are braces. These are braces that there's different types that my patients use. And then I'll go over those whenever I do. There's a surgical shoe, which is just a flat shoe, and then diabetic shoes. Okay, so those are the order types that I use. My most common medications. So when you pull in surgical medications, it'll pull in all of these, and then you just delete the ones that aren't given. So the way I do surgical medications is, let's say I have surgery this Wednesday, I will prescribe them usually within 30 days prior, but they don't show up at the pharmacy until 2 days before. So I'll show you how to do that. What I do is I put them in there. I change the date, so they'll show up in the pharmacy 2 days before the surgical date. Okay, and so the most common ones that I use are they're getting ibuprofen, which is just pain, and they tend to get, and the prescription's already there, but it's 3 times a day, whether they have pain or not. Vistaril, they usually take this with the pain medication. I use this, it's an antihistamine, but I use this to help take away any nausea when they're taking the Percocet. So these are the most common 3 that I give here, the combo, ibuprofen, Vistaril, and Percocet, and they're pre-set up in terms of the amount that I give them. Occasionally, if they don't want Percocet, I'll give them Vicodin, and occasionally, if they're a risk for a blood clot, I'll give them Lovenox. Okay. There's a couple of other pain medications occasionally I'll give my patients. If they have like plantar fasciitis or Achilles tendonitis, they might get naproxen, ibuprofen, or a Medrol dose pack, which is prednisone. It's little blister packs. The most common antifungal medication I give my patients is Lamisil, 250 milligrams. It's called Lamisil or terbinafine. This is used as an antifungal. The way I do it is I do it daily for 90 days. Then I give it weekly for another 30 weeks. And then I'll do it daily for another 90 days if it's needed. I do it a little bit different just because I get better results that way. So basically they're going to take a QD for 90 days, then I see them back, and then I'll give it weekly for another 30 weeks. Now, when we prescribe it, I don't prescribe it as if they're getting it weekly though. I prescribe just 30 once a day. And the reason I do that is because otherwise they have to go to their pharmacy and get 4 pills at a time. And so I tell them verbally that they're going to get it they're going to get it, take 1 pill a week, but they're going to get the pills all 30 at once. Okay. And then I'll see them back. So basically they're going to see me in 3 months right here in the office. Then they're going to see me in another 6 months. And then they're going to see me in another 3 months. So there's 3 visits there. And I'm doing this. Now, normally, most of our pharmacies, some of the most common ones here are called CVS and Walgreens. They'll cover the first 90 days, but after that, I usually have to send it to a different pharmacy where they just pay cash. And it's inexpensive. It's about $10, $10 to $20 for these other ones. But most insurances have a limit on the number of pills that they give patients, because when the original research was done, they only thought they needed 90, but I find if I don't give them it longer, it tends to reinfect before the toenail totally grows out. Okay, so that's why I do it that way. So this is, so you'll hear me say that a lot. Occasionally, if these they can't tolerate this one, I may give them itraconazole. I may give them Sporanox. Very rarely though, so I would say 95% of the time I'm giving them Lamisil. These are antifungal for skin though, so there's a difference. So these couple right here are for nails, and there are a couple that you can use for skin as well. So ketoconazole can be used. that's for skin, and then these other two can be used occasionally for the nails as well. So fluconazole is also used for like a vaginal fungal infection, and Jubilee is a topical. I only give this if patients really ask me for it. I don't think they really work that well. Okay, and same thing with the topical. There's other ones, but this is the most common one that I use. There are a couple of wound medications I'll give them. Santal is one. This is an enzymatic debrider. So basically, if there's fibrotic tissue, I'll give it to them. Regranix helps heal wounds as well. And then Amerix collagen powder is something that we dispense in the office. And these come in either 15-day or 30-day kits. And this is considered a durable medical equipment. So you'll see when we do that, there's different ways of ordering it. It's going to show up differently in the medical record. Antibiotics, the most common I do is cefdroxil, which is kind of like cephalexin, 500 milligrams. You're familiar with this one, Chandru. And I do this for 7 to 10 days. The reason I like it is because it's twice-a-day dosing. I find if I give them Keflex 3 times a day, they don't usually, they might miss a dose. And then I have a couple of gout medications I give. I might give them indomethacin, a Medrol dose pack, or Colchris. And occasionally I'll do compounded medications. I don't do that many, but this is one called P4. So those are the medications. As I mentioned, any questions on that, Chandru or Ben, or should I keep going?
No, Mr. Dan, I have clear about it.
Okay. You're going to get bored of me. I'm getting bored of myself, but we'll keep going here because we have to push through.
Doing
No,
great.
You're doing
Okay,
great.
good. Thank you. So I did a report in the last 10 months. This is my diagnosis code usage report. Okay, so ICD-10 codes, these are the names of the codes. And so if you look at something, there's something called the 80-20 rule, right? So 80% of the time I'm using 20% of these. So if you look, like it's going to be the first maybe 50 that I'll use. I might go down to here. Yeah. So 13 times. But these are pretty much all the ones that I use. Okay. Let's start with the most common one. Plantar fasciitis, or is for heel pain. Okay. Tinea unguum is like a fungus in the toenail. These are generic codes, pain in the left, pain in the right foot. The reason we use these usually is to coincide with an x-ray. So you have to put what foot it is. Ingrown toenail, very common. It can be infected or non-infected. Pain in the toes, corns and calluses, hammer toes, which is a curvature, a bending of the toe, diabetes, hammer toes, once again, other specified peripheral vascular disease, PVD, which is usually used for our circulation studies. Contracture of the left ankle and right ankle. These are used with someone who has equinus, is a tightness of the calf. And you have to have this diagnosis if you're going to give someone one of those night splints that I talked about. Bunion, right foot and left foot. PVD, once again, same thing, peripheral vascular disease. Calcaneal spur is usually used when I'm getting an x-ray. I don't usually treat spurs, but we use that for the diagnosis for the x-rays. Type 2 diabetes with neurological complications, that would be diabetic neuropathy. Type 2 diabetes without complications. Plantar wart, which is a verruca also. Non-pressure chronic ulcer of the right foot limited to the breakdown of the skin, and of the left limited to the breakdown of the skin. So these are the ulcer codes that I use. This is a cellulitis code that I use. Usually when we're doing an ingrown toenail, they'll have cellulitis of the right or the left. Idiopathic neuropathy. So a lot of my patients have neuropathy, which is numbness or tingling. We don't idiopathic, we don't know what it's caused by. Tinea pedis is for athlete's foot. Cellulitis is an infection. Osteoarthritis is arthritis, right, of the ankle. Metatarsalgia is pain to the bottom of the foot in the metatarsal region, localized edema. I'll use this code if I'm doing a Uniboot, which is one of those tight wrap boots I told you about before. Osteoarthritis of the left ankle, once again, metatarsalgia. Other specified congenital malformations of the skin. This is usually used for something that I call a porokeratoma, which is basically a clogged sweat gland on the bottom of the foot. And so I'm treating that with usually the salicylic acid stuff that I put on there. The salicylic, not the cantharidin. Achilles tendonitis, right and left. Flat foot, right or left. Pain in the ankle. Onycholysis, which is a detached toenail, so the toenail is detached. So when we were doing LFTs, we needed to put in, there was liver disease. We don't really do this anymore, but we put this in. I may even delete this. I never put this in here, but like, because when you're doing blood test, you have to give a reason for doing the blood test, and that's what we're using. Posterior tibial tendonitis is the pain on the inside of the ankle. There's a big tendon that comes down. Abnormality of gait, I might use this if I'm doing an evaluation for balance. Hallux valgus, which is a bunion. A lesion of the plantar nerve. This is usually for a neuroma, which is a pinched nerve between the metatarsal heads. Hallux valgus, pain in the right ankle. Other specified disorders of the bone and foot. There's some like pediatric things, and they'll come up as these that you might put a specific name in there, but it'll come out like this with this kind of generic term here. Other acquired deformities. Once again, when it comes out generic, it's usually I'm putting in a specific name in the medical record, but it's popping this up. Hallux rigidus is arthritis of the big toe joint on the right. Posterior tibial tendonitis. Type 2 diabetes, cellulitis, changes in skin texture. That's like if someone have like fissures in the back of the heel, like cuts in the back of the skin, not a wound, but just a cut in the skin. Peroneal tendonitis. So the posterior tibial tendon is on the inside of the ankle. The peroneal is on the outside of the ankle. It's another tendon. Lesion of the plantar nerve. Once again, it's a neuroma. Just regular dermatitis. I see a lot of dermatitis. Bunionette. There's on the inside of the big toe. There's a regular bunion. A bunionette's on the outside of the fifth. So the first and the fifth metatarsals can have either a bunion or a Taylor's bunion. Peroneal tendonitis is on the outside. Some patients have type 1 diabetes. Bursitis is like almost like a sac of a fluid, or almost like a cushion that your body makes. Usually it's under a callus or an area of friction. Epidermal thickening. Once again, callusing. Idiopathic gout. Enthesiopathy, which is where a tendon inserts into a bone. Nail dystrophy, which is just like a funny looking nail. Charcot foot. Charcot is a condition where the foot breaks down due to diabetes and neuropathy, and they can't feel it, and they get a broken foot, and it's called Charcot foot. Hallux rigidus, once again, is a big toe joint arthritis. Bunionette, which is the one on the outside. Stress fracture. Sprain of the ankle. Idiopathic gout, a ganglion cyst, which is a fluid-filled cyst. Other enthesiopathy, once again, we talked about that. We have these things called like chronic kidney disease. The reason these are in there is because if someone has, they get nail care, they have to have like kidney disease or some other condition like neuropathy or diabetes to get it covered. This is one of the things that covers or allows insurance to cover their nail care. Flat foot, acquired keratosis, which is just a callus again. Congenital pes planus, which is a flat foot. Generalized atherosclerosis, which is clogging of the arteries. Ganglion cyst, unsteady gait. Hereditary idiopathic neuropathy, again, once again, neuropathy. Non-pressure ulcer, once again, kidney disease, which is a reason for nail care. Sprain of an ankle, type 1, type 2. Overweight, occasionally they'll put that in there. Mononeuropathies, nail disorders, stress fracture. Chilblains or pernio, these are conditions of cold that affects the toes. Once again, type 2 diabetes, progressive neuropathy, drug-induced neuropathy, an abscess of the foot, a cellulitis of the foot, a pressure ulcer, a high-arched foot, which is called pes cavus, skin changes, obesity, dermatitis, pes cavus enlarged, thick toenails. Now we're getting some of the fracture codes, which aren't that common. You can see I've only had 8 in the last 11 months. Raynaud's, which is the same thing, kind of like chilblains, but your toes kind of get white. Scarring of skin. Kidney. Once again, these kidney diseases go with the nail care. Parkinson's disease, dry skin, xerosis cutis, Charcot. Foot drop. Occasionally people have a foot drop, usually because of some type of a stroke, instability. Osteomyelitis, which is a bone infection. As you can see, we don't do a ton of bone infection patients, okay? So it's not a lot of that stuff. Swelling, non-displaced fracture of the fifth, non-displaced fracture of the phalanx, which is the toe, a sprain of the joint. These are some of the really rare ones. Benign neoplasm, critical illness, once again, neuropathy, rheumatoid arthritis. That's where they can get nail care covered, so that's why they have rheumatoid arthritis. Drop foot, stress fracture. specified juvenile osteochondrosis. This is called Sever's, which is an open growth plate into the heel, where the Achilles tendon inserts into the heel and causes heel pain in kids. A fracture of the fibula, contusion of the big toe, displaced fracture, non-displaced fracture of the second or fifth, and these are fracture codes, and they code a little bit different when we're doing them. Diabetes, neuropathies, pressure ulcers, blisters, contusions of the foot. So there's a lot of different diagnoses here. These are a lot of different diagnoses, but most of them are pretty repetitive. Okay, lymphedema, varicose veins, type 1 diabetes, pressure ulcer of the heel, pyogenic granuloma, which is usually on an ingrown toenail. Someone's going to get a big thing of tissue on the side of the toe. Hallux varus, flat foot, spontaneous tendon rupture, neuralgia, stress fracture, osteomyelitis, which is a bone infection, osteochondritis dissecans of the ankle, which is avascular necrosis, which is like the bone, kind of like we're concerned that the bone is dying because of the lack of blood supply. Kidney disease, anesthesia of the skin, mass, a contusion, a blister, some like fracture codes here, elevated BMI. Man, look at all these. Okay, I'm getting tired, but I've only done these twice, so I'm not going to worry about these. I'll go over these other ones if they show up. Okay. Okay. So I don't use much telehealth. This is an old telehealth template. Let's go into talk about X-ray templates. So X-ray is of the heel, foot, ankle, or ultrasound. So X-rays of the heel, this is how it's going to show up. Here are the X-ray templates, and basically what happens is you're just going to have to pick what's normal or abnormal. So you just pick those things in there, okay? And I'll show you how to do that. That's ankle, or that's heel. Here's the foot X-ray, my template, and I'll show. It's going to be easier for me to show you what the options are when we go into that a little bit later. This is by far, now there's a new search function within Athena that you can search my macros or any macro, but I copied them or I exported them all right here. So the way you put them in is with a dot code. So like if you type in dot post, it'll pull up like post-op types of things within the Athena. And so these are like a first post-op visit, second post-op visit, abscess, ankle brachial index. So my whole goal, Chandru, is like when I'm seeing patients, I try to finish the note. I do currently when I'm in the room. Occasionally I get tired and I can't. And I'm hoping like when I'm talking, you'll be able to supplement that with the things that I'm talking about and document more. Like you can pull in these macros, but then I'd like you to pull in more of what I'm talking about. That's my whole goal. So I can, because I'm not very, how do you say it, detailed when I write. I get a little bit tired. So I'm really excited to have someone that can help me kind of start with these and then make them better. Like you start with the template and then kind of more things when I'm talking about, it can make it better. Just, my whole intention is that. So like I can pull these in, it's super easy, but I want to give more attention to the patient and then make my notes better. So that's why I'm hoping that you'll be here with me to help. Abscess of the foot, accessory navicular. I'm not going to go over all these. You can read these. But then what I would do is I would just Google any questions you have about these. But once again, I use most of these like some are more common than others, okay? And I'll kind of guide you which one you're going to use, but there are tons of, these are called macros. And even when you're making a note, let's say we're doing something new, you can edit these macros or you can even make your own macros. If you see I'm doing something common or you want to put a couple of them together. But there are tons of different macros. And so normally I'll show you what I typically do, okay, with those. Let me see here. These are, once again, so macros are what I'm saying to patients. So macros go in the description, okay? These also go in the description, okay? These are called my description templates. So basically, when someone comes in with plantar fasciitis, what normally happens is this pops in, it'll pop this in, and then you'll delete the things that I don't talk about, okay? You'll get used to that as we do things, but I have it kind of designated some intro thing in here, okay? And then to reduce inflammation, we're going to try these things. And like, let's say we're not going to do compression sleeve, you just delete that. So I have everything pops up and you delete what I didn't talk about. Same thing with reduce tightness. You know, whatever I don't do, you can delete. Reducing stress and strain, you can delete. And then these other things you can delete if I don't do them. So I pull in everything and you can delete it as you need to. AFO notes, ABIs. Okay. So that's a lot. And I'm going to go into the medical record now. Any questions so far?
No, Mr. Don.
No, sir. I think everything looks great so far.
Okay. So when you pull in, depending on the office, I'm in Westboro currently on Mondays, and then the rest of the week I'm in Worcester. So Westboro I'm on Monday, Worcester the rest of the week. And then other certain days, like usually once a month or twice a month, I'm in surgery, depending. So today I'm in Westboro, so I'll pull this up. So when we look at the schedule, I blocked today until you arrive, or until we were doing this. So that's why it says it's frozen right here. And so I start seeing patients at 1 o'clock. So the first thing you're going to see is the times of the appointments. My appointments are every 20 minutes. Okay. I usually see patients from 8 in the morning until 4 o'clock is my last patient. Most lunch hours I'm doing like I have a podcast and a YouTube, so I might be recording YouTube videos. I might be doing a podcast. I might be doing something else like that. That's what I usually do in my lunch hours. So today, once again, you can see these patients. That's my Tuesday, so it's pretty filled. And there's openings, like if there's an opening, there's a patient opening there. But so there's Worcester, and then here's Wednesday, and here's Thursday. So there's, as you get along, there's some more things that'll fill in. Friday is my routine day, which is, so I typically do all my nail care patients on Fridays. So it's a lot of new from old, meaning old new visit. It's a nice day. It's a little bit more intense. You can see usually on the hour they'll double book. So 8 o'clock there's 2 patients. I guess 8:20 there's 2, 8:40 there's 2, 9:20 there's 2. So they tend to double book, or triple book, I guess. But they're quick visits. They're quick visits, and they're just nice. You do the nails, do the calluses. I get to chat with them. Okay, and then this Friday I think I'm only there till noon. So you'll be able to see the schedule. There's different tasks for me to do, certain cases. I think over time we can like talk about those, but that's kind of less important right now. Let's go into a test patient. So here is a test patient, Amy Test. Okay, so what you'll see in a patient's chart, there you can look at their allergies, different problems that they have, medications that they're on, vaccines, the vitals, which are inputted by staff, nail sample, like fungal nail samples, ankle brachial index, which is a circulation study. And you can look at the results from x-rays, things like that. These all pop into here. Visits, these are different. This is just a test patient, so there's orders. History, this is all done by staff. And then quality and care. I think that's for MIPS. Okay. Within a patient's chart, you have these options up here. You can do an overview, create a case, create an order group, and I don't usually use these other things. I use this third-party application. So let's start up here. A quick view, if you want to just kind of look at the patient's chart, if they have any balance, their name, their email, their preferred pharmacy. Sometimes you have to update what pharmacy they're using, what lab that they're using, and then the other visits. Occasionally, if you're in a hurry and you just want to schedule, you can create an appointment tickler. Let's say you forget to do it. You can just click create appointment tickler and it'll create a tickler for the staff to do that. Okay. So that's how you do that with that portion. If you want to get back to who I've seen lately, you can click this up here, this little hourglass, and it'll go to the last patient that we just saw. You can also look patients up by their patient ID, their birth date, social security number, or you can go look at the recent patients that I saw, okay? If you get here and you want to get out of it, you can just go to, if you want to get to where the chart is, you can go to click clinicals and go down to chart, okay? But there's a couple of things right here. This is my staff use this. I don't use this as much, but registration, you can send a message about the patient. We don't usually use these that much. Schedule appointments, this will be done by my staff. Billing, you don't usually need to see that. Chart, you're going to usually use this chart thing right here. And then occasionally I might have you like create a case in the future. So basically what a case is, I'll show you that. So creating a case is just something about the patient, let's say, and you have to choose who's doing this case. So the patient, I'm the provider, and what's the, so for example, I'm on call on the weekend, for example, and I'll get a call and I'll say like patient call, and then I'll say, you know, patient called the office on the weekend, okay? And then when you do this, you can then say what type of question it is, okay? Patient no-show, administrative, clinical question. If they have a question, staff will send those over. And then what I'll do is it'll automatically pull in for me, but there's a couple of places it can be sent to. So Pelto staff goes to my staff. I might want to send it to one of the other doctors. So there's Dr. Kellner here, or there's Dr. Feldman here. And so I can send it over to Feldman or a staff person. Like if it was Feldman's patient, Dr. Feldman's patient, I could send it over to him and he would be aware that the patient called over the weekend. Okay, that's how you use that. Once it's complete, you hit data entry completed, and then it'll pull into my staff bucket and they'll do something with it, okay? And I can also just close and I can say it's completed, unable to complete, or scheduled, okay? So that's how the cases work. Order groups, occasionally, let's say this Amy Test wanted an antibiotic or something like that, you could create just an order, and I went over all those order things for you in the past. I don't know where the orders are, but they were somewhere. I just want to go back so I can show you, because this is how you're going to refer to stuff. So within order, there are order types right here. So there's a lot of different radiology orders, lab orders, other orders, things like that. So within Athena, you usually have to have to do an order, you usually have to have a diagnosis, okay? So there are certain order sets that are already set up. You can see there's 207 order sets. There are different diagnoses, and there's different common orders, okay? And there are point of care tests. So let me go over these. Order sets are, for example, if I'm going to see a patient for nail fungus, it'll pull in the nail sample thing that I talked about. Let's say I'm taking a nail sample on this patient. So this is it actually puts in the lab. I send it to, and I'll like a PAS, which is that test for fungus, and I'll tell you what nail. So right hallux, for example, or right big toenail, and then I'll fax this over, and it'll go over, and they'll know it's a nail clipping, and I'm determining if there's a fungus in there. Okay, and then I just hit sign order, and you'll have over time. I think you'll have signature options. So LFTs, I talked about liver function test for fungus. These are those 5 surgical medications that I talked about. If they have athlete's foot, it has the prescription for that medication, the ketoconazole. For DME, that's a night splint. MRI, the Performix, that's a compounded cream. Exoform, gout, the Arizona braces, Achilles tendonitis. Now, a lot of these are basically just Achilles tendonitis left and right, and just diagnosis codes, okay? It's just choosing right and left. So I don't use these that much, okay? I don't choose the diagnosis only from there, though, from these order sets, okay? Going back from order sets, you have diagnoses. These are the most common diagnoses that I see, and these show up in here. There's different orders. These are the most common orders. Hepatic function, which is the LFTs, physical therapy referral, the terbinafine, the orthotic, uric acid, CBC. I don't do these. And then point of care tests. These are all those x-rays I talked about. 3 views, ultrasound, calcaneus, foot views, things like that. These are orders if I want to put in here. Let's take a chance and put in these orders for the x-rays. When you do an x-ray, you have to have a diagnosis. So you can either use foot pain, plantar fasciitis, something else like that. A lot of times we use foot pain. Now with foot pain, you have to specify what foot it is. This is something that's key, because if there's only foot pain but there's no diagnosis, it'll make you choose one. So you can pick right, you can pick left, or unspecified. We try to avoid doing unspecified, but they might have it in both. So you can do right, and then you can also do left. So you can pick 2 of them. And then for the x-ray, this is what I talked about before. You don't have to fill out any of this stuff. You just have to fill out this. Okay, so for x-rays, I will go through, and you have to pick, is it the right side or left side, or bilateral. Normal findings, no evidence of bony abnormality, adequate bone density, bones and joints, good alignment, soft tissue normal limits. And if they're a kid, you can put in growth plates visible. Okay, so a lot of times I'll select all 3 of these, and if it's a kid, I'll select this one. If not, I'll leave it empty. And then these are all the findings. Okay, the most common ones I'll write here in other. And so for x-rays, the first intermetatarsal angle is like a bunion angle, and I'll give you a degree for that. You'll put in first MPJ with asymmetric joint space, which is a big toe joint, has poor joint space. That would be arthritis in the big toe joint. Arthritis in the big toe joint with spurring on the top. So basically there's going to be a spur on the top. First ray elevatus. This is something I see on the x-ray where the actual first ray goes up a little bit. 4th and 5th intermetatarsal. So this is the bunion angle, and this is the bunionette or Taylor's bunion angle. And you'll click it. So to put in degrees, you'll double click, and you put like 7 on left and 6 on right, for example. So you can put on right, on left. That's how you double click. Amputation noted. Accessory bone, you'll double click, say where the accessory bone is. Arthritic finding noted, you put where it's at. Bone cyst noted, where it's at. Bipartite sesamoid noted, so that might be the tibial or fibular. Tibial is the inside, fibular is the outside when you're talking about sesamoids. Calcaneal inclination is the elevation of the angle. Bone cyst, calcaneal spur, that's in the right, left. Calcaneal inclination, normal, increased, decreased. Dorsal spurring of the first MPJ, right and left of loss. Diffuse osteopenia. This is like someone has osteopenia, osteoporosis. Elongated like second metatarsal. Exostosis, which is a bone spur. A foreign body, which is like a piece of metal in someone's foot. Hallux abductus interphalangeus. This is an area where the big toe goes in a little bit. Okay. So here's hammer toe. I'm training the scribe.
Oh, good.
So let me show you an example of a x-ray. So normally I'm going to be pulling up an x-ray and I'm going to be looking at it. And so for this one, what I would say is there is arthritic change on the first MPJ. You can see it, and there's reduced joint space laterally. And then if I go to the side view, there's also spurring on the top right there, and it's also elevated higher. Okay, the calcaneal angle is normal. So for this patient specifically, what we would do is the calcaneal inclination is normal. There was first MPJ with dorsal spurring and asymmetrical joint space. And then there was first ray elevatus. So I would talk you through this as I'm looking at the x-ray. And that's all you would have to do for that. Okay, if that's for this patient. Let me see if I can find another patient here. So once again, normal x-ray. There's a 5th toe hammer toe. So on the left, there was a hammer toe. So what you do, hammer toe left on the 5th. Heels look fine. There's a little bit of a spur, very small spur on the right heel and none on the left heel, and normal heel angle. So the heel angle was normal. It was bilateral foot, so I'd write bilateral in here. And And what did I see? There's a little spur on the right. So calcaneal spur plantar on the right. If there was a spur on the back right here, that's called posterior spur. Sometimes there's a spur here and sometimes there's a spur on the bottom. Okay. If there's arthritic changes, it would be degenerative changes. If there's a phalangeal fracture, I'll tell you where the fracture is. I don't use these other ones that much, but there's other areas where there can be fractures and kind of where it's at. I would kind of walk through. We do also ultrasounds. So occasionally you'll see an ultrasound. This is a patient here. They have a thickened plantar fascia. So let me just show you how to do that. So it was 6.4 millimeters. So for this patient, we would do, if you just start typing, ultrasound. And so, yeah, that was an old one. So for ultrasound, you're going to pick point of care tests right here. And for this one would usually be done with like plantar fasciitis. So I'm looking at the right one. So plantar fasciitis right here, you pick that. And then you would attach it right here to plantar fasciitis. You could delete this heel pain. So for plantar fasciitis, this stuff pulls in automatically. You can just leave that. So for this ultrasound, it has areas where you're going to focus when you're documenting ultrasound. So the imaging studies, Achilles, forefoot, plantar, ankle joint, or other exams. So for this one, we did an ultrasound of the right. It's initial imaging, or if it's repeat. And then for this one, it's plantar heel. So the plantar fascia is attached to the calcaneus proximally with no tears, effusions, and no calcifications. So this is correct. It's not normal because it's thickened. I evaluated it in the short and the long axis. This is the long axis. This is the short axis. There's plantar spur. There's no, I don't see any spur here. There's no, I guess there might be a little bit of a spur right here, but I'll tell you if there's a spur. And to measure it, I just measure it right here. Let's say it's 4.8 millimeters. 4.8 millimeters. There's thickening of the plantar fascia, and it was measuring at 6.4 millimeters. You can see this one. And then any of these other things I would tell you, okay? Tarsal tunnel, ankle joint, and then other exams, which is usually for like a tendon or soft tissue mass. So we'll kind of work on our way how we're going to communicate about doing these things for the X-rays. But that's how you kind of do X-ray or ultrasound reads, and I would kind of just be more verbal as I'm doing that. So and then once these are done, I think you're going to have, I think you sign off as a scribe for these things, and then I like kind of co-sign them. Okay, so let's go back to Amy Test here. Let's pull up one of the encounters here so I can show you how to edit this. Okay, so this is an example of an encounter from Amy Test. I'm going to amend it. So as I showed before, we'll kind of assume this stuff automatically pulls in from the medical record. The main part you need to be worried about is like the physical exam. So let's talk about physical exam. Physical exam and procedure. So physical exam, as I mentioned before, there are certain findings that are saved. The most common one that you're going to use is foot pain normal. And once again, saved finding pre-populates everything. So there's foot pain normal, routine normal. Those are the most common ones. And then CDFE normal. I tried to have a master one that never really worked for me. So actually, who's going to actually set up the templates is usually my medical record, my medical assistants. As they're putting the patient in, they're going to choose the one, but sometimes they choose the wrong one. So you still need to know how to like delete the old one and make a new one. Okay, so let's say it's a foot pain normal. it's going to pull in all the normal values that I mentioned before. And then, for example, let's say that other patient that we're talking about right here, let's say their circulation is normal. Let's say you want to, if the dorsalis pedis is absent, you can just switch to absent. They had edema on the left side. Their skin, let's say they have a lesion. Let's say they have a thick toenail. Oh, there's nothing here for thick toenails. What do? Well, you come up to the top. You put in here nails and calluses only. Remember those only ones I said? So nails and calluses only. Post-op, it's down here. Post-op exam, wart lesion only, wound only. So these are the ones that are going to pull in those only ones. And that's something important. So nails and calluses only. So within the skin section, it's going to pull in, they had a callus, let's say, the hyperkeratosis, which is a callus on the first met head, for example. You put that in there, and then it's painful. And then on the nails, now I said before you have to say which nails. Let's say on the right foot, they have the first and the fifth nails that are thickened. So you put 1 and 5 right there. And normally I just click all these. So elongated, thickened, discolored, dystrophic, superficial debris, sublingual debris, and pain and palpation. These other ones I don't usually do. Usually stop at pain and palpation, unless they have like a subungual lesion, which is like blood underneath the nail or something else like that, or hemorrhage. And then these other things I'll let you know if they have like an ingrown toenail. It's incurvated on the medial side and the inside or the outside of the nail. Proximal nail clearing is used when someone's on oral antifungal, and what you'll see is at the base of the nail it'll clear, and that's what I usually see when they're taking that oral antifungal. So that's how you add the nails and calluses to this one. And then let's say their gait, they have a limp, a waddling gait, shoe gear. Sometimes I'll say specifically what type of shoe gear, and I'll mention that you should put that in there if they're appropriate, inappropriate. Musculoskeletal. The most common thing I change is like the range of motion limited. So a lot of times what I say is they have equinus noted with knee extended and knee flexed. And that means just tightness in the calf. If they have pain, a lot of times I'll say they have pain on the plantar medial heel, or they may have it on the plantar central heel. That's for plantar fasciitis, or they'll have it on the posterior central heel. So that would be where the Achilles tendon inserts into the back. They may have a high arched foot, which is called pes cavus. They may have a flat foot, which is pes planus. A lot of times with pes planus, what I'll say is they also have heel eversion is noted. So that means the heel is kind of tilted to the side. It's everted. There might be a prominence, like a bony prominence. And these are the two bunions I talked about. The bunion on the inside, which is the hallux valgus, and the bunionette, which is called the Taylor's bunion. Okay. They may have, I don't usually use these that much. The most common one I use here are the hammer toes. So if they have a big toe hammer toe, second toe hammer toe, third toe, fourth toe. And then I can put if it's flexible, semi-rigid, or rigid. And that just means with the hammer toe, if I can straighten it with my hand, it's flexible. If it's semi-rigid, I can straighten it a little bit, or if it's totally rigid, I can't straighten it at all. And that's the difference, and I'll verbalize what's going on. If they have tenderness, I'll say there's tenderness. I don't usually use that much, the tenderness part. And then neurological, the most common ones that I use are like sensation, vibration is not detected, and I'll tell where it's not detected. I might do it for paresthesias or anesthesias where they can't feel a portion of their foot or their toe. And then Tinel's sign is something that on the inside of the ankle, on the tibial nerve, is where there's like a shooting pain. If you tap there, the peroneal nerve, it's at the midfoot. If you tap it, there's like a shooting pain. And then there's also one that can happen at the fibular neck, which is on the outside of the upper leg. Valais sign, I don't usually do that one. And then Sims-Weinstein, which is that little, it's a monofilament, 5.07 monofilament, where I tap the bottom of the foot to detect neuropathy. And so if it's detected, they can feel everything. If it's inability to detect in a certain area, it means they have usually diabetic neuropathy, but it can be caused by some other things. And then this is the muscle testing, if the muscle is weakened. So those are the physical. This is the most common thing that I do is musculoskeletal stuff because we're kind of podiatry or orthopedic type of stuff. I also talked about, I'm going to pull these in by themselves just to show you. I talked about before post-op exam, so it's going to pull in this stuff here. So healthy, well-nourished, well-developed. Actually, that's a post-op one. There's a different one I like for post-op. Actually, here's the post-op normal. So it pulls in everything, and then the inspection is left open. So post-op exam, the location, let's say they did a bunion, so it would be right bunion region. If they have swelling, I'll say swelling, and so you put in swelling. If there's redness, I'll tell you. If there's pain, if there's a wound. If not, you can just leave it empty. If there's drainage, if there's signs of infection, you can put that in there. If the sutures are intact, pain with palpation, any cellulitis or an infection, any dehiscence or gapping in the incision, any granulation, that just means there's, for a wound, it's granulate, good healthy tissue if the incisions are normal or abnormal. If it's abnormal, there might be like, let's say, like gapping to the incision due to swelling. If there's hardware, like pins sticking out, so intact, let's say like present in the second digit. Position, so meaning it hasn't pulled out, and then if the toes are well aligned. So that's for the post-op visit. And then I talked about before for wounds. Wound only, this is an old one I had, so there's a new one. I would use this one. So for wound only, for this, once again, type of a wound. Most of mine that I do are diabetic. Very rarely do I do a venous leg wound, but I'll tell you if it's a venous one in the leg. Pressure ulcers more to the heel region. We don't do that many. Burns, we don't do that many. Venous leg, we don't do many. So usually diabetic. Ulcer length, width, and depth. What I mean by that is I'm going to measure it. And so it's going to be the length and the width and the depth. So it might be, and it has to be in centimeters. So let's say I say it's like 5 millimeters. What you have to do is you do 0.5. So 5 millimeters is 0.5 centimeters. Okay. So 0.5, so let's say it's 5 by 5 by 2, 5 by 5 by 2, so it would be 0.5 by 0.5 by 0.2 centimeters. Okay, if I'm telling you in millimeters, you just convert it by putting a 0 point before it. Tissue depth, most of mine are either dermis or subcutaneous. The stage is usually partial or full thickness. Most of mine are full thickness. Occasionally there's partial thickness. Drainage type, I have to put, like if it's serous, serosanguinous. If there's no drainage, you just no drainage. There's none. But most of ours are a little bit of drainage. Drainage amount, mild, moderate, or heavy. Most of mine are mild. Drainage frequency, if there's drainage, it's going to be daily. If there's no drainage, you just don't put those. Okay? If there's no drainage, you don't put those. If there's drainage odor, present or absent. Tunneling. So tunneling would be meaning under a wound, it would tunnel in a certain direction. So you would put yes, and you would put where it would be tunneling to. So you could be tunneling distal. You usually say like what o'clock, what time period. Like if it's an ulcer on the bottom and it's like to the 12 o'clock, it goes straight up. If it goes to like the 3 o'clock, it goes to the side. So I might say 3 o'clock and 6 o'clock. And so what you would put is like 3 o'clock. And those would pull in there. Necrosis, and it has to be colored when you do that. Then the location. So let's say it's like the plantar first met head. And if you want to see what's written here, you can just click on it, and you just have to scroll through to see what's written in there. And then the date it began. Put in the date like it would be today's date. So it would be 11/28/22, and then the initial size. And a lot of times what I'll do for the first time, I'll just copy this one right here, and I'll just put it in here. And then when they come back, I can change the size. So when you pull a new from old, you'll just change, let's say it's down to 2 millimeters the second visit, you can just put that in there for 2 millimeters, so it's getting smaller. Okay, so that's how you do a wound. And then there's also wart lesion only, which would be for like warts. A lot of times I'll use this if there's just one, but if there's multiple, I'll just put it in the germ section. Okay, like first med head, fourth med head, third med head, in different places. We can kind of work on that if we need to as time goes on. I can kind of show you how to do that. Okay, that's physical exam. And that's what you have to really worry about is the physical exam and then the procedures. Once again, all these procedures, if we go back here, all those procedures are right here. These are all the procedures that I do. Okay, and so what you'll do is you'll just click on here and it pulls in, there's previous procedures and then all my templates. I have 125 procedure templates, and I use many of them, but for like a lot of them you have to say where stuff is at. So for example, for calluses, bilateral foot, but you have to kind of put where they're at. So it might be like the left first med head and right second med head. So you have to do 2 to 4 lesions. So you have to put kind of where they're at. And I'll tell you where they're at. That's for lesions. For ulcer debridement, let's say it's the left. If it's not in there, you can type it in, first med head. If I usually use a scalpel and tissue nipper, I get off the hebikeratotic ring if there is one that's just callousing around it. Devitalized tissue. If it's fibrotic, like where I'm using the Santal, I'll use fibrotic. Or if it's necrotic, that means it's like dead black stuff. Usually it's devitalized. I usually debride into the dermis. Okay. If there's like fat present, I'll do the subcutaneous tissue, or if I'm going out of the capsule. And then you have to do the total amount that you're doing, how many square centimeters. So to do that, what you do is you take the size and you multiply the length and the width. And that's how you get to the square centimeters. So for the other example, we did 5 by 5. So it was 5 by 5, but it wasn't even 5 centimeters, it was 5 millimeters. So, all right, so you do, like if it was 1, it would be 1, but 1 times 1 would be 1. So a lot of mine are small. They're usually going to be like 1, 2, or 3. That's what most of mine are. And then what I put on it, if I'm doing betadine, Amerigel wound dressing, or wet to dry, usually I'm putting it on betadine or Amerigel. And that's how you document the ulcer. Now for ulcers, there's different things, right? So I usually use, this debridement of skin, 20 square centimeters or less. That's the most common one that I use. If it's more than that, like if it's a really huge one, I'll tell you to add an additional. So for each additional 20 square centimeters, so up to 20, you do that one. After 20, you do this. I don't do a lot of big ones, though. I've never used that. If it's to the tissue or muscle, meaning it goes deeper, I'll tell you to use this deeper one. Okay. And if it goes down to bone, there's another one that kind of goes down to bone. Okay. I very rarely have them go to bone because that means you're like taking out bone as you're debriding it. And so I rarely go that deep. Or it might go down to bone, but I'm not taking the bone. Okay. So that's the debridement code. Injecting the small joints, like I mentioned before. Incision and drainage of an abscess. This would be like more for ingrown toenails. So if this is something we do all the time. So left, a great toe. Usually it's like the medial hallux, lateral hallux, bilateral hallux edges, or different areas. So it might be like the left medial hallux. That's a really common thing that I do. This pretty much stays the same. The only reason you would put more in here is if I'm doing bilateral. So like if I'm doing bilateral medial hallux, you have to change this from 3 cc's to 6 cc's. And that's what I usually do in there for incision and drainage. So we talked about, so the nail debridement as well for this. Once again, if they're thick nails, if it's the first and the fifth, like I went to before, the first on the right and then the fifth on the right, you have to put which nails are thickened, and I'll tell you which ones are thickened. So if you're doing that, then what you're usually doing is you're doing the trimming, and use the new one, okay? Trimming of the rest of them. So if first and fifth is in here, then for the other ones, you have to do second, third, fourth, and the rest of them down here, unless they have a toe amputated. And the way you do that is you click on it, and you hit the down number, the down, and that's how you select it. Okay, so, and then to delete it, you just kind of delete it like that. But to select it, you have to hit the down. So over here, and you can do Shift Tab to go backwards and Tab to go from one to another. So Shift Tab goes back, and then tab goes forward. So for this one, Shift Tab, it shows up, I click down, and then I hit tab, and then that's how it selects it. Okay, same thing up here, put down, and then tab. Same thing with these ones. You can just hit down, 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 and that's how you kind of go through. And then once they're done, then you can just do new from old. So this is very common on a Friday, doing this and the callus stuff on Fridays. We talked about nails. So for EPAT, this is something that we do here. EPAT, this is combo. This is where you use focused and radial. So I'll put like where it was done. Let's say the right, like plantar heel. I'll put what type of tip. I'll tell you. It's usually I use the gold tip, but occasionally use a ceramic tip. And then I'll give you the settings. But normally the settings are 9 at about 3 for about 1500 to 2000 pulses, and then that's for the radial, and then the focused, which is also called EPAT. Then there's a focused one. I usually use the tall standoff, which just means it's just a higher thing and it doesn't go as deep. And then this is what I usually used for the settings, is usually at an 8.35 and about 2000 pulses. So once we do this, the first time, the other ones are just new from old. And the way I do shockwave is I usually do 3 sessions. The reason I have different documentations are sometimes I have the radial one is only in my Worcester office, and the radial and the focused one is in my Westboro office. So depending on that, which one we're doing. Okay, that's how you do the EPAT documentation. Injecting tendon sheath, which is a pretty common one, I'll do for the right plantar medial heel, which is the plantar fasciitis. And if I'm doing it with ultrasound, I'll type in here with ultrasound guidance. And then usually I'm using 3 cc's unless I tell you less. And then it has everything else in here already. So that's how I'm doing the injection of the plantar fascia. This is the radial EPAT, which is just a single machine instead of two machines. Here's for the keratomas, which I showed you before. This is for the abscess. That's for the ingrown toenail. Here's the lesion destruction. These are the ones. This is the one I'm using selenocaine. So there are 2 things that I use. There's one's called selenocaine, and it's based on the number of lesions. So let me show you this. So if you type in lesion, so there's lesion destruction 15 plus, and then there's, I'll show you these all right here. Okay, so let's start with lesion destruction. This is where I put salicylic acid. This is not as intense. Okay, and actually I'm going to get over one thing right here. The other thing is right here. Okay, so let's start here. So first is lesion destruction, less than 14 lesions. So most of mine have less than 14 unless there's a really big wart or multiple warts called a mosaic wart. And so I'll kind of say where they're at. So let's say it's usually, and this has to match my physical exam findings in the note. So let's say the right first met head, second met head, and a little digit. Okay, and then that's where they're at. And this kind of goes over how I did the lesion destruction. If there's 15 or plus, what I'll usually do is I'll do like let's say it's bilateral feet, and then I'll say like on the right first met head, mosaic wart. Or I might say like multiple midfoot warts, something like that, so they know there's more, like 15 or more. Okay, that's how you do the lesion destruction. Now, cantharidin is something else that I do here in the office. That's where I put it's Beetlejuice, also called Beetlejuice. And so if I do it, I'll say where it's at, same thing, and I'll say how many lesions that that's the difference here. Difference here I don't say, but here I'll kind of write in the number of the lesions were debrided. If it's or was debrided, depending if it's 1 or more. So if it's left first met head, that's only 1, I would say that it was debrided. If there were left first met head and second met head, they were. Okay. Cantharidin at 15 or more, you have to kind of say where some of those are, where they are. And then I also use for warts, I also use Cutera laser, which is another laser I'll use. Sometimes I'll do these in conjunction, so I might do cantharidin. I might do laser first and then cantharidin. And then for this, you'll say where it's at. If it's new, recurrent, improving, resolved, and then the Verruca number, if it's 15 or more, or if it's less than 15, and then the energy. So usually if it's lower, I'll put 140, or if it's higher, I'll do 180. Usually I try to do 180. The joules I'll tell you, but I think it's usually 10. And then the pulses, I might do like, I usually do 3 each wound, each lesion. So let's say there's 3 lesions, I'll do like 9 for that, okay? So let's say there's 3 of them, I'll do in 3 of them, 3 at a time. So that's how you do warts. Matrixectomy is a really common procedure that I do here as well. So a matrixectomy is where I totally remove a portion of the nail. So it might be the right, it could be the medial hallux, lateral hallux, which would be just one border, or it could be the whole toenail. And then the only reason you would have to change the amount is if I'm doing bilateral or multiple toes. So let's say I'm doing the right hallux, medial, and second digit medial, or something like that. So I would need 6 cc's instead of just 3 cc's. Okay. And then when you do the billing sheet, you're going to have to change the number of units that we did, or if it's bilateral. Okay, that's how matrixectomy. That's for toenails. So carry-flex is a procedure where I put on a fake nail on someone's toenail, and I'll say where it's at. It's like the left great toe, and how many I do. Let's say there was just 1 nail. It's usually I'm just doing 1 nail. Okay, talks about carry-flex. Injecting a small joint, which is usually like, let's say the right first MPJ, that's first big toe joint, or some other smaller joint, and it has and if I'm doing it with ultrasound guidance, I'll put with ultrasound guidance on there, okay? And then I'll say how many cc's I put it in there. Let's say it's 2 cc's. I do also some other injections. I'm going to let's do all those injections right here. Okay, I don't do much of this, but occasionally we'll do an amnion injection. So let's say you're doing it into the right, you have to type a lot of times, plantar fascia. I'll say how many cc's. Okay, so it's usually like 3 cc's, and I'll put in which one we're using. So I usually use, it's like a half cc, mixed sterilely with usually like 1 cc of saline, creating a total mix. You add those 2 up, 1.5, and I was just putting the right plantar fascia again, was pre-marked, and the 1.5 cc was injected into the fascia by resistance, patient guidance, or with ultrasound guidance if I want to add that in there. I told them not to take anti-inflammatories. Usually I tell them to not take that for a couple weeks. So that's our amnio. This is not very common. Okay, this one's more common. This is for plantar fasciitis, injection of tendon sheath. So let's say the right plantar medial heel. We're doing like 3 cc's, which is the most common. Injection of a large joint. This would be like the right, like an ankle joint. It's a bigger joint, and then I'll do 3 cc's in there. Injection of the neuroma. A neuroma is a pinched nerve between the metatarsal heads. This was performed on the, let's say the right third interspace region, and we did like, let's say 3 cc's in there. And if I did it with ultrasound guidance, you just put that in there. Okay. Then occasionally I'll inject a ganglion cyst. So what it says here, the cyst was prepped with 2 cc's of lidocaine injected into the skin surrounding it. I pull out the stuff first, and then I inject it. Okay, so I pull out the ganglion stuff in there. So that's the right dorsal midfoot. I'll inject it, let's say, with 1 or 2 cc's. Injection of a tendon. This is similar for the plantar fascia, but let's say I usually am injecting one of these other tendons, like the peroneal tendon or the posterior tibial tendon. So let's say I'm doing the right PTT tendon. but you can type it close to your tibial tendon with ultrasound guidance. I'm usually doing it. And then I'll say how many cc's I'm injecting in there. So those are all the different tendon stuff and different injections that I do. There are a couple of other ones. If you trigger point or neurolysis, I don't do that much anymore. And injection of scars, very rarely. Occasionally, if it's a really bad scar, I'll do that. Okay. So that's injections. Occasionally for scar, I will do laser treatment. So I'll put like the location of it. Let's say it's on the plantar foot. Is it improving, resolved? Is it new? And then here's the laser things that I'm doing and the amount of pulses that I use. Occasionally I do. I don't do that a lot. Okay, that's for scars, procedures, bias joint, Cantharidin matrix, Cariflex. So there's also fracture codes. So when you're talking about fracture, it's not actually that it's a procedure. It's more of a billing thing, but it's saying that I didn't have to do any surgery on these patients with fractures. So there's some that are for metatarsals, for toes, for strapping of the toe, for a digit, for a tarsal bone, for a calcaneus, for a great toe, for the talus. So they're all pretty much the same. I'll give you a couple of examples here. The most common ones. So fracture, closed metatarsal without manipulation. So this procedure was performed, let's say, on the right second metatarsal. So for a patient, for example, they have a stress fracture on the second metatarsal. Fracture was identified on an X-ray of the second metatarsal. And it's close enough anatomic alignment that does not need open reduction or manipulation. If I did need to manipulate it, let's say it came out and I had to manipulate it to put the toe back into joint, that could be the right second metatarsal. And the fracture was identified of the second metatarsal. It was close enough and it doesn't need open reduction. This is without manipulation. There's one with manipulation. This just says that I manipulated it. Okay. So that's how those are for the fracture. So I do those. So that's only done the first visit when I see someone. And the main issue is when I do this for patients, I can't bill an office visit for 90 days. I think it's 90 days. And so that's kind of how that works. Okay. I can bill x-rays, but I can't bill office visits. And so it pays a little bit more. But I also can't do any other office visits unless it's for another condition. So we talked about joints. Let's just go into all these here. And once again, all these procedures, you can see what they are, and this is just kind of showing how I set them up. Onifex is something I attach to the toenail, injection neuromas, nail avulsions. Skin biopsy, this is something I do. I usually do these in tandem, so let me show you these. So the most common ones I do are these two right here, single lesion and additional lesion. So let's say I do this the right plantar foot. I always do 2 millimeters. And so I'll do one there, and then I'll do a second one there, 2 small ones. I like to do that so I don't have to throw a stitch, a suture. So if you do like 3 millimeters or 4 millimeters, you have to do something bigger, and you have to do a stitch, okay? I usually do additional and a single and additional. Occasionally I'll do a nail punch, which is usually on the right, let's say it's like the great toenail. And then I'll numb it up. I do a 3 millimeter punch for that. It's in the big toenail. And then there's also, I can do a different one where I take another nail sample as well. Okay, so there's the biopsy codes. Who's getting tired besides me? Hope you guys are still listening. You guys still around?
Yeah.
Oh, come on, Ben. I'm dying here. I'm dying.
How you doing over there?
This is worse than seeing patients. Is this what you were wanting? I'm hoping this is what you were wanting.
Sometimes you got to be careful what you wish for, you know. No, this is
Yeah.
perfect. Absolutely, it's great.
Yeah, I can go over all these other things, but I'm tired. So what else do you want me to
Okay.
show you?
Whatever you prefer. I mean, whatever you the essentials, and I mean any information is welcome, and we're definitely thankful for it. But we also don't want to overextend your your courtesy or your time here either. So whatever you prefer is it's entirely up to you.
Yeah.
Basically, just
Go ahead.
oh yes, just I would definitely go through maybe um, like a summary or a review of how to put in maybe an entire note and maybe another test note. Um,
Okay.
but maybe if you'd like to wrap it up, you can. It's entirely up to you. I don't want to overextend your time. You've already reviewed a great amount, so whatever you'd like.
Yeah. No, I
Or
just
if you'd
want to
like
make
to
sure that
put a
Chandru
break in.
is fine with this because you're going to see me do it. We're going to connect on Teams and you're going to see me as I'm doing it on patients. That's the easiest things because most of the time it's the same thing over and over. And it's just, you have to learn kind of the nuances of it. But you're just, the only two things you have to worry about are the physical exam. So picking the right template. And usually my staff picks that and then filling it in and then picking the correct assessment, which they'll put in sometimes, or I'll tell you, and then you have to do the discussion. So, and then a couple of other things while I'm here. Usually I'll send letters to the doctor, so they'll have their name in here. So you'll send a letter over and you'll hit add. That's how it sends a letter to them. Okay. And then also another thing that is connected here is called third-party applications. This is something pretty much every patient's going to get content from me. So it's called Patient Education Genius, and it'll automatically log in to that. And this is something more advanced once we figure it out, how to do things. But I have all my patient resources on the left here, so in alphabetical order. So let's say they come in for Achilles tendonitis, and I'll just say, well, send the stuff that's there. So you'll click these two things, you'll click send, and you'll send it over, either text it to them or send it to their email. Okay, and so this is what I do for every single patient, where I send them information via this thing called Patient Education. It's totally integrated with Athena. Okay, so that's something that's really important for me to know, for you to know. But I think you'll just kind of pick it up. I would just, once you see me do it, then you can kind of go back and look at the resources and see kind of how it goes.
If we could, before you run, would it be just okay to go through a sample HPI and then a sample assessment and plan, just how you would approach it, so he gets kind of an inside, preliminary idea, and then he could see how you approach it and how you would follow through.
I've never done a HPI.
Oh, great. All right, so not necessary in the HPI, primarily
So
the templates for.
let me show you how you would do it if you were going to do it. So once again, I have staff that do the HPI. So they'll tending to fill it out, but it's probably a good idea for you to. So once again, well, this is the thing that I'm looking for someone to help me out to make mine more detailed. So as I'm talking to them, so it's called history of present illness. So as I'm talking, usually my staff fill it out, but I don't think it's very good. So certainly as I'm talking to them, you're going to be filling this out. So HPI, there's different templates for it, right? Foot pain, fungal toenails, procedures, follow-up visits. I don't do these that much. Usually my staff does it. So they're going to pick one. And then you're going to pick like the left, let's say it's the left plantar heel. They have like a burning pain, sharp, dull, severity. One thing that gets me mad, just so you know, is that when they click these and they don't put in a number. So like, let's say the pain level is like a 9. So don't leave it empty if you're going to pick something, or you can just do mild, moderate, or severe. Same thing with like days or weeks. If you're going to put in months, put in like how many months, like 3 months. Timing, if it's acute, if it's chronic, if it's gradual, the context, how it happened, anything that makes it better, alleviating things. Like if they, for like a lot of heel pain, they might take anti-inflammatories. They might have tried physical therapy. They might have tried icing it or elevation, and things that make it worse, like if they're standing or getting up in the morning or something else like that, they'll talk about, like in the morning, if they're getting out of bed. And then any associated symptoms that they have, previous surgery, prior imaging, if they come in with x-rays or an MRI, if they've had injections, you can put that, or if they've had any other previous treatment. So that's how the HPI is done. I would like my HPI to be better. So I think, yes, as I'm talking to them, as you're listening to it, if you could add in other stuff based on what I'm talking about. That would be great. Review systems. We don't do a great job with review systems because normally what we do is we just hit brief review of systems and everything is normal. What needs to change though is usually musculoskeletal or skin. So for example, if they're here for plantar heel pain, you're going to have to put like there's soft tissue swelling, or you have to put like take off this and put like plantar heel pain or something like that in a musculoskeletal. Or if there's skin issues, you can put in like there's skin lesions, or if there's pain, or if there's thick toenails. And it really depends on what you're seeing, because if we're doing a brief review of systems, it's gonna be different than if I think you could. They're more of a comprehensive one, but you can kind of pick which ones are in here, and then any neurological symptoms if they're having numbness, tingling, things like that. So that would be the review of systems. Once again, a lot of times what our staff do, which is unfortunate, is they're just pulling in this normal and then they're leaving it totally normal. So if you can add some things into the review systems, I think that would make my notes better, which I don't do. And then past medical history, they usually put these things in with the staff. Same thing with surgical history, they'll put that stuff in with the staff. And then where I spend most of my time though is the physical exam, procedures, and then assessment and plan. I think that's where I spend most of my time because that's where I spend all my time. Is that good, Ben?
That's definitely great. If you could just in finality here, if you could just do the assessment and the plan with the codes, and then just how you would finalize the note.
Okay.
I know that you touched on that earlier, but.
Yep. So for assessment and plan, let's say, so something pretty common is plantar fasciitis that I see. So let's say they've got x-rays. Let's say they got an ultrasound. I don't usually use both, but let's say they have these things done, okay? And I've put in here discussion. So once again, I didn't go over this, but okay. So within here, under my macros, so these are the dot codes. You dot something else. So to find it, you just Control F, and like, so if you want to see what I use for plantar fasciitis or something else like that, I'll kind of teach you how to do it. But basically, for this one, for its plantar fasciitis, you do dot and start typing, and it'll pull in what it is. You click Enter, and it pulls in everything. This is the part that I need help with, okay? Because you can add more in what I'm talking about. This is where I really want the help. And like, let's say I talked about rest, oral anti-inflammatories. We're not going to do a cortisone, so you delete that. He's not going to do shockwave or compression, so you delete that. And then you do the physical exam. They're going to do deep tissue massage. They're going to do, let's say, the morning routine. They're going to get new shoes. So everything else that you don't do, you delete. Okay, and then they might get an X ultrasound in the future. They're going to make a follow-up with me. Let's say they're going to see me in 6 weeks. You can put that in here. What the appointment's for. Most of my appointments are like an NE10 or NE20. But if let's say they're getting let's say they're doing Cantharidin, you can choose that. If they're getting a cortisone injection, you can choose that. Cyst follow-up, EPAT focused, EPAT radial, established patient visit, follow-up with x-rays. If it's a fracture and they're getting a follow-up with x-rays next visit, you can do follow-up with fracture. If they're doing Cariflex, that's that thing I'm putting on their Lamisil follow-up. You don't always have to choose these, but it just helps sometimes. There's a lot of different options you can choose. But for like plantar fasciitis, they're going to just see me in 20. And I might put some notes in here. I might be doing this too, because this is how I communicate with the staff. So I'm going to say they need like a foam roller. And that's going to go to the staff. And then in the billing sheet, eventually I'll teach you how to do this, but like you pick like a new patient level 3, choose the x-rays and then the ultrasound, and that'll go in there, and you just hit sign and close. And yours won't close, yours will just sign it as a scribe. So let me show you how that was going to work. So at the end, where is it here? Actually, this is an amendment, so I can't really show you here. But on the other ones, at the last page, you can click up here. There's a button up here where it says that was done by a scribe. Okay, but that's how it'll come to me. Does that make sense? Hope that helped. There's like so many other things. You're just gonna catch it when you see me doing it.
That all looks fantastic. I apologize. Maybe I should have planned you in a short break or a breather, but everything was great. I mean, the detail in it is very helpful, so definitely appreciate that. Chandra, did you have any additional questions before we close out for the day?
No, I didn't have any questions, Mr. Don.
Okay, I'm tired. I'm sorry. I wish I had more energy, but that's a lot.
Okay.
Oh no,
Okay,
coming off the
understand,
holiday and
So yeah, I'm excited. I think next week you're gonna be shadowing me. So basically, I'll log into Teams. I have my phone in my pocket, and then you can just watch me do stuff. So I think that's how we're doing it.
sounds great. We definitely appreciate your time and help. And sure we have quality notes and we'll review everything before as well for in preparation.
Okay. Yeah, and then I think I have some block time. For me, Chaudhry, it's going to be better usually at the end of the day where I can just review the notes with you as you're learning to do them. It's a little bit harder for me in the morning. We can do a little bit of something in the morning, but it'll be a little bit easier at the end of the day if that's okay with you. Okay, Chadra?
Yes, Mr. Don. It's okay for me.
Yeah, so I said it's a little bit easier for me to help you at the end of the day than it will be in the beginning of the day because I have a couple young kids. So I'll try to get here a few minutes early to review the schedule with you. That's my thought is I'll kind of review the schedule, show you what's there. And another thing that you could do is it's called prepping. So that's what my staff do. So if you have time, you could even prep the notes. There's a way you can do it. I don't know what it's called, but you can like you can prepare. Yeah, you can prepare the note, and then if they don't show up, it'll just delete all that. But you could prep the note if that would help you to kind of look at the notes, see how it is for the patients in that day.
Okay, done.
And then I wanted to know from you because a lot of times I'm recording videos or doing interviews. So during those times, I'll probably just pause my Teams, my Microsoft Teams, so you don't have to listen to me jabber. Okay?
Okay. I understand, Mr. Don.
And then if you need to contact me, you can use this thing called this chat. I'm assuming you're going to have I don't know if you're in here yet. You probably have something in here soon, and then you can just type messages right here, or you can use however you want to do it, but you could just communicate right through here and send me a message if you need me. Okay?
Okay. I get it.
Good. Okay, gentlemen, that was fun.
Thank you.
Absolutely. Thank you again for everything. We hope you have a great rest of your day.
Yeah, if you could give me a copy of that, if you have it somewhere, that video, and I'll put it in here as well into my little Athena thing. Okay?
Oh, absolutely. Can do.
Okay, Ben. Thank you, guys. Thank you, Chandra. Very nice to meet you. Looking forward to chat more.
Thank you, Mr. Don. Nice
Okay.
to meet you.
Have a nice day, guys.
Thank you, Mr. Don.